So, good morning, everyone. My name's Marie Gerald. I'm from the HAS team, the Homelessness Advice and Support team at the MHCLG. I sit alongside our Rough Sleeper advisors, and I believe Lucy's on the call as well, in case you have any rough sleeping specific questions. And what I thought I'd do today is just kind of stay with the theme and kind of give you an overview of some statistics. It's very brief. And then obviously if anyone has any questions, just post them in the chat. For those of you that are from a local authority, there is some stuff in here which I hope you know, because it's just demonstrating what goes on with the HRA. And then we'll move on to some statistics. So I haven't got control of this PowerPoint, so would we move on to the first slide, please? So for those of you not from an LA, this just kind of gives an overview of the Homelessness Reduction Act, the 2017 Homelessness Reduction Act, which was enacted in April 2018. It gave the biggest change to homelessness legislation since the Act began. And the legislation introduced new duties to all household, which are prevention and relief. And that's irrespective of whether someone's in priority need. And what this meant was that more people became eligible for assistance, and in particular, single households, which were traditionally not helped a great deal under the old legislation. Sorry, the admitting keeps coming up in the middle of my screen, making me lose my flow. One of the biggest changes was the time frame for threatened with homelessness increased up to 56 days from 28 days. Prior to that, what was happening is that people weren't getting help in time, and therefore everything was being managed at crisis point. And the other significant change was the introduction of HClick. If you're from an LA, you obviously love this. And that we now collect a lot more data than we previously did. And it kind of gives us much more detail about the background to some of the homelessness applications that we received. And looking at the data, it's very difficult to compare the data before we got HClick due to some of the definition changes and reporting styles. And there's an easier to read flow chart which kind of goes through the process, shows what's a duty and shows where there's an assessment, and it also shows where there's an outcome. So that's a handy little guide for those of you that aren't au fait with the HRA. Thank you, my lovely assistant. So this slide here really just shows the main categories of homelessness and the duties that vary between them. And just as just to clarify, the families and the most vulnerable have a duty to be housed, and that's from the outset, but most single people do not. So the people still owe the main housing duty are mostly families. And those that are in priority need, and it primarily includes those with children, those with vulnerability, including disability and mental ill health. If with this main duty, there is a duty to provide temporary accommodation until suitable settled accommodation is found, whether that be in social housing or whether that be in the private renting sector. People that are not owed the main housing duty are single people, and previously under the old Act they wouldn't be helped because they're not eligible on immigration grounds, or they've made themselves intentionally homeless, or they're not in priority need. But what the Homelessness Reduction Act has created new duties to try and prevent and relieve homelessness for single people, regardless of whether they're in priority need or intentionally homeless. I think the fundamental thing to understand here, though, is if we go through the prevention and relief duties, they will not have an accommodation duty if we fail to relieve homelessness. And also worth mentioning is LAs have received additional funding to help assist rough sleepers. And that goes on to the final category of people sleeping rough, which goes on to say that most rough sleepers will be owed Homelessness Reduction Act duties, whether that's prevention or relief, unless they have no recourse to public funds, but not necessarily the main housing duty. Some, of course, will have priority needs, and amongst most vulnerable rough sleepers are the people that have lost access to the main duty. So they've been through the system, they've lost access to the main duty, or no longer want this type of assistance. It's more difficult to assess rough sleepers under homelessness legislation just because of the challenges of trying to put together a personalised housing plan, losing contact, etc. So that is a bit more difficult. So I'm going to move on to the statistics now. And this is just kind of a summary. We recently have got the full year data for April 2019 to March 2020. And this is kind of some of the headlines. Prior to the Act, people with children made up the majority of owed and main housing duty. Since the introduction of HRA duties, more single people are owed an initial homelessness duty, which is 66.2%. And single adult households are the largest group of households owed a prevention or relief duty, which is a significant shift, and that's representing about 60% of all households. Those likely to be owed a prevention duty are single households than households with children. However, someone let Mark in. However, households with children are more likely to approach at a prevention stage. We are still seeing a lot of single people approaching at the relief stage or at the crisis stage. So we know we need to do more work in trying to prevent single homelessness from occurring in the first place. Thank you. So what I did was pull out the data for this session on support needs of applicants. So total number of households that have identified support needs was around 135,000. However, of those, some had more than one support need recorded. So altogether, the total number of support needs recorded for this period was 285,000 odd. The highest support need still remains those with a history of mental health or suffering from mental health. This has been consistent through all of our stats releases. We know that more work needs to be done in this area. And around 16.5 drug dependency needs identified, and around 12,000 and 12,500 had alcohol dependency needs identified, so quite significant. And if we move on to the final slide, you can see how that compares with the other support needs. So by far, a history of mental health problems is and remains the highest support needs. And then further down the line, you can see drug dependency and alcohol dependency. Second highest support need is physical ill health and disability, and domestic abuse still remains up there. So that's the end of my bit to introduce the presentations. I'm just having a look, see if there's any questions. No one's got any questions before.
Great, thanks, Marie. Just quick on the data, is that across the southeast, or is that generally across
nationally?
The country? Nationally, lovely. Do we have that for the southeast at all?
You can break it down. There is tables that you can do that too. Okay. It would just take a little bit of work to try and have a look at that.
Lovely, thank you. That leads us nicely into Andy and colleagues. We're going to put that into perspective in terms of what that looks like in terms of helping colleagues co-design services and commission services that kind of take some of those aspects into consideration. So I'll hand over to Andy and Izzy first of all, if that's okay.
Thank you very much, Emma, and a big good morning to everyone from the Shires of Oxfordshire. So I'm just going to introduce myself. My name's Andy Simmons. I am the Senior Operations Manager, CQC Registered Manager of Oxfordshire. I worked for Turning Point for far too long. I think I lost count at 25 years, and closer to retirement than I am to kind of starting as a young street worker. I did manage a service in central London for 20 years and have been in Oxfordshire for the last 5, really. I'm really pleased that we've got Izzy with us this morning. You want to say hello, Izzy?
Hello, my name's Izzy and I'm from the Hep C Trust, peer support lead for the Thames Valley area.
Fantastic. So I was asked just to kind of talk a little bit about Oxfordshire's response to kind of COVID-19. So I was going to talk a little bit about the setup we have in Oxfordshire, talking a little bit about how we responded to COVID-19, with a particular kind of focus on homelessness, particularly in Oxford and also in Bicester for ourselves. Looking at kind of pathways into kind of mental health, into other kind of partnership working, some of the lessons I think we've kind of learnt within COVID-19, and then looking a little bit about how we do co-production and co-design with people who use our services. Izzy's then going to talk a little bit about his experience. He is someone who's been through our service, currently works for the HEPC as a peer support worker, and has been a great help with our Hep C treatment services, and then talking a little bit about what makes us proud, and then what may be the next steps kind of looking forward really. So for Turning Point in Oxfordshire, we have probably about 85 staff. We've got a consultant psychiatrist as our clinical lead, a clinical psychologist. We've got lots of recovery workers. We've got lots of peer mentors and volunteers in the service. Probably got about 14 nurses. Fortunate with those, and probably got about 10 prescribers, most of them kind of independent nurse prescribers in terms of that. So hopefully some of us remember a life before COVID, and in Oxfordshire, for ourselves, in terms of kind of opiate substitute therapy, generally in last year we had 1,621 people, mostly within we've got 4 main hubs, one in Banbury, one in Didcot, one in Oxford, and one in Whitney. And we have a large share care service as well with 27 different practices. One of the things which we were an entirely script in hand service. So generally in the core service, we have just over 1,000 people who we see every 2 weeks. We also, probably about 3-4 years ago, we have a segmented cohorts of OST, which means we've kind of split. We have an engagement, which are people coming into services, people who may struggle with appointments, people who are at that front end. We then have a kind of core, we have a reduction day as well, and then also some specialist ones in terms of workers and safeguarding as well, really. We are generally, I suppose what puts us apart a little bit, certainly within our engagement, we generally have kind of managers who manage that front end, who, you know, we're very keen on getting that same day treatment start. And generally across the whole service, we are a non-appointment service as well. We do our best, not surprising, I'm sure for many of you, is that appointments, many people struggle to kind of keep and stuff like that, but generally I can tell you our engagement days, where we generally have probably about 50-60 people coming in the afternoon, they're great days to work, of which they are all entirely kind of based on harm reduction, naloxone, BBV and the rest. Alcohol, so, you know, in the last year we had almost 600. We've got a dedicated alcohol service in Oxford, and increasingly doing with non-opiate users as well. We did lots and lots of groups before COVID struck, probably 6-7 groups in each of our hubs every day. That's a mixture of kind of front-end groups in terms of harm reduction groups, through to the back-end mindfulness. I think before then we had something like 9 mutual aid groups as well, particularly some of the fellowship groups as well, which we ran across the services. We do lots of outreach. I've already mentioned the 27 shared care practices. I think we also did 22 outreach sessions every week. I think we are very much a service about looking outwards, engaging with the local community. So we did lots of stuff in terms of homelessness. There's a number of direct access or at the front end kind of homeless agencies in Oxford, also the Salvation Army in Bicester. We also work with children's social care as well. We have got workers embedded within the 8 children's centres across the county. And we do an awful lot of kind of community as well, really, which are kind of community venues. So the south of the county, quite rural, and therefore we've got 6-7 kind of rural locations that we do every single week prior to COVID. We're big on collaboration. I'll talk a little bit about mental health in a minute. We do a lot of work with our ODN and Hep C treatment. Our community hepatology team from the JR are just lovely, brilliant, wonderful people who we work with. I think in the last 18 months, we've treated over 120 people entirely within community drug services and also homeless venues as well, which has been fantastic. And we do a lot with criminal justice as well. So we have just under 100 people on DRRs. We attend the Crown Court every week and the magistrates every other week. So we are very much closely working with the criminal justice. We do a rehabilitation pilot or project, which is linked with people on DRRs, which are overseen by a High Court judge at the Crown Court, Judge Ross, which, you know, for the first time, certainly in many years I've been doing, kind of got that integrated treatment across not only within the kind of community at the front end, but going into Bullingdon Prison. And then out into residential treatment and then back into the community as well. If I have one plea, I think, in my next life, I'd like to be a High Court judge, because he has been absolutely fantastic about breaking those barriers down to, particularly through prison and back out into the community. The last bit, we like a lot of fluffy bits as well in Oxfordshire. So we do have a CAF in Oxford, entirely run by volunteers. We have been funded, very fortunately funded by the Police and Crime Commissioner for the last 5 years. There's a big focus on offenders coming out. We were getting day release from Spring Hill Prison. We have lots of people coming through DRRs, through the courts as well, who kind of staff that. Which has been really good. We've got a recovery house that's very much in collaboration with a local housing kind of charity. They do the housing management. We do all the kind of recovery support, and tends to be for people returning from kind of residential rehab back into the county. We've got lots of peer mentoring across the county. We think people with kind of lived experience coming through the service bring a real kind of freshness, diversity, and kind of welcome bit. And we do lots of kind of, you know, one of the things that I'm often struck by is something we call growing our community, where people coming through doing well just want to give back to the local community. And I'm just we do lots of stuff, like I'm a bit of an old hippie and stuff, kind of gardening projects. We painted entirely just before COVID in one of the kind of nurseries. Lots of community going out. We're just doing a community orchard at the moment as well. So some really good stuff before kind of COVID, and also very fortunate that we got an outstanding in our last CQC. Next slide, please. And then COVID kind of came. So just to give you a little bit about how our response in Oxfordshire. Oxfordshire is a very diverse county. There is an awful lot of prosperity in the county. There's an awful lot of rural areas. There is also lots of areas of deprivation as well, really. And I suppose our model was very much based on that, really. I remember at the start of March, we implemented this just before the lockdown came in, that everyone came in, had to wash their hands. And I suppose I was struck just by service users or people using the service, I think I probably had a few more problems with staff making sure they were washing their hands every time. But people soon got into the bit about wearing a mask and washing their hands. I remember one particular chap, he was less keen on washing his hands. I had a quick chat with him. I think he blew something like 122 on the breathalyzer when he came in. But even he, in the end, preferred to wash his hands rather than spend half an hour with me talking about it, which have that effect on some people. I think one of the things that influenced us as well is we had a great foundation. So I think in the previous 12 months, we'd given out almost 1,300 bits of the lock zone. Being a script in hand service, we knew our service users very well. And therefore, having a strong foundation, having those relationships really stood us in good kind of stead. I think the bespoke delivery was really kind of key for us, particularly the way in which we saw the pandemic and cases within places like Oxford. Was very, very different to what we saw in some of the rural areas, and therefore we kind of very much based that on the kind of how we kind of rolled that out. We continued face to face, so in somewhere like Oxford where we saw between 100, 120 people a day, we went right down, seeing about 10 people a day. And obviously, like many other places in terms of doing our risk management we did continue to see kind of new starts, titrations. We should continue to see children's social care, particularly those on in care proceedings, particularly those on DRRs, doing kind of drug testing for their orders and stuff. So, we did a lot of kind of face-to-face still, but clearly the biggest thing we did was probably kind of hit the phones, really. And I think for us, having that kind of contact, but, calling people. I think most weeks, particularly in that early lockdown between the end of March and the start of the end of June, when it kind of came, we were making 3,000 phone calls a week to people, just to make sure that people were kind of safe, they were engaged, and that they were kind of doing okay, really. So the other bit as well, we spent a lot of time on meetings. It's probably the bit at the bottom there, really, a lot of times. And I suppose I had lots of questions about what is your procedure, what is your kind of process within this. And I suppose the way we chose to do it, we generally just said, give us a call. And we probably had a lot of people answering the phones. We had a lot of people contacting, but just ensuring that our number one thing was to ensure that people kind of kept in treatment, kept safe, and that we were responding to kind of local need. We were very kind of lucky in terms of we had very few pharmacies kind of actually close during the lockdown, so that was great. We did extend in terms of kind of our outreach, so particularly a response in Oxford. We had 124 rough sleepers that were accommodated in 6 hotels in Oxford. And we did some really fantastic works. Mungos are just wonderful people to work with, where we before they were opening the hotels, we sourced them both with naloxone, with lock boxes, with injecting equipment and stuff, and just trying to set up, and really pleased that we kind of accommodate all, but I think it was about 10 people who, despite offers, wanted to stay on the streets. And generally, because we stopped a lot of other services, we kind of had a bit more time, and therefore we were able to go into those emergency accommodation kind of almost every single day, and just making sure that people were in treatment, which was fantastic. We also was doing the Salvation Army in Bicester as well, in there a couple of times a week. And I suppose particularly in that initial part, doing that kind of harm reduction was exactly, we have a great working relationship with the police as well in Oxford. I can remember one of the officers' community support team ringing up about one of the homeless rough sleepers, saying, unfortunately he's not got anything, and therefore we did know him quite well. We managed to get a script, and one of the workers popped down with a script. So I think it was about 45 minutes it took us to get us into treatment, and for him to get a prescription. The next bit, just in terms, so we went from kind of being script in hand to hand delivering all our scripts. So generally that was to the pharmacies. We had weekly calls. I think particularly one of our great relationships is with pharmacies. We do kind of pharmacy checks on everyone we have in treatment with us, and therefore knowing your pharmacist and us as a service knowing them very well was incredibly important for us. We didn't have a kind of blanket wide what we did. I think one of the things we found in Oxford was pretty quiet during the lockdown, many of the workers not there and stuff, and therefore particularly people in the Oxford hotels, we did keep on daily pickup. Obviously we were looking in terms of kind of safety. We saw things very differently in the rest of the county. We saw long queues in some of the more rural locations, and therefore we very much looked at exactly what we were doing. And as a manager of a service in the overall, we probably looked at a lot of data within the whole cohort, and generally in March we stepped people down. So if you were generally on a daily pickup, we then moved you to 3 times a week, and then moved you to kind of maybe weekly a pickup, really. So I think, generally we probably all the way through the pandemic, mainly because of our work with kind of rough sleepers and the ability and what we were hearing from pharmacists, probably continued to have about 20% of our cohort on daily pickup. We released or slowed down the actual supervised consumption, but the daily kind of pick up. And then, we didn't have, I think at the height, we only had about 10% unfortunately. So we did have lots of people who were obviously shielding people for whatever reasons that coming out was. So it's about dealing with that as well. Alcohol, just in terms of our response, we've noticed, like many places, we've certainly had, so certainly on the opiate side, we've not really seen a lot of people coming into treatment. New people that we never knew. We've seen some people that had fallen off the script. Some people, we have quite a large, particularly in the rough sleeping cohort, that tend to come in and stay on a script for a couple of weeks and then they fall off for whatever reason and stuff. But certainly in the alcohol, we saw a fairly big increase, 25%. And I suppose our big focus was about ensuring that every single person was contacted on that day. And we did our best to ensure that people got that. So most of the treatment in alcohol, we have continued our community detoxes right through the kind of lockdown and also the pandemic. But a lot of it is on the kind of telephones as well. And just the last one there, just on collaboration, I've already mentioned some of the great organisations. I seem to kind of spent half my life in meetings and about talking, but I think the response in Oxfordshire was fantastic. And just coming together, whether it be on kind of domestic abuse, whether it be the homelessness, whether it be the tactical police meetings, was just fantastic. And even the DRR court reviews, Judge Ross says, I'm going to do them on Zoom. We had to go out. Unfortunately, we can't do Zoom on our computers in Turning Point. I had to go and buy a computer so our criminal justice worker could get online. And we did, I think it was 94 DRR reviews within the first quarter of this year. So please don't tell me IT department. Good. Next bit, slide. Thank you very much. Mental health collaboration. We do some great stuff with mental health. Mental health is incredibly tricky, as I'm sure most services or the kind of co-occurring mental health and also substance misuse are very lucky. We have Dr. Theo, who's one of the consultants in the assessment team before the pandemic, does a session in our Oxford hub looking at assessments, looking at our joint work with those with dual diagnosis. We also, our clinical psychologist is quite involved, particularly engaging with those maybe doing discharge plans from mental health wards. And looking at that, so they did actually go online. We did virtual meetings when the immediate lockdown, but Theo came back in June and looking at that kind of bit around how we work. And particularly around, we did renew our dual diagnosis protocol, and that's a really great way to kind of look about how we work, particularly where it be with Talking Place Plus, which is our IAP service. Mind, we have been doing sessions in response housing, but how we work on that kind of day-to-day kind of around service users who present with both mental health and substance misuse. We do a lot with shared care. Like I said, we've got 27 different practices around the county. We also have a walk-in GP, Luther Street Medical Centre in the centre of Oxford as well. We do a shared care within there 4 days a week. They also have a mental health practitioner in there, which has been very useful. And certainly over the years, we do a CPD event for GPs. Last year we had, I think it's about 37 GPs turned up. We had a focus on alcohol and working with alcohol, which was fantastic. And we've done a lot of RCGP training over the first 3 or 4 years of the contract, and worked very closely with the LPC as well, which has been brilliant. I think the relationship we had with pharmacists throughout the pandemic really kind of helped us enormously, just having that kind of first name terms, getting through to pharmacists, letting us know when they had problems and ensuring that we could ensure that everyone stayed on a script within that. I think one of the things we've done an awful lot during COVID-19 is around that mental health well-being. We've done an awful lot around sending newsletters out, linking in with kind of a number of kind of apps, I think one of the things we've heard a lot from our service users, what they've really liked is the worker, which they know quite well, ringing them up quite regularly. And whether that be once, twice, 3 times a week, and just checking everything. And I find the service users' response to COVID has been really interesting. And, we clearly, some people have struggled. Clearly, some people's mental health has really kind of been affected. But we have seen lots of people who've done really well. People who actually for the first time did get their hours of exercise, did actually use the time to look at how they were doing things. So it just goes to show us that, I suppose, that, ensuring that people are different and how we do that. Next one, please. How am I doing for time? Okay.
Yep, you've got a few more minutes.
Oh, good. I talk a bit quicker then. Sorry, I wasn't sure whether you'd all gone. And so just in terms of outcomes, keeping people safe was our main one. Just in terms of the lock zone, in terms of treatment, I'm really pleased. I think we've only had one potential drug-related death in the last 6 months. We did an awful lot about how we keep people safe. We did an awful lot, particularly in the emergency accommodation. Our experience in Oxford, particularly in the lockdown, the immediate lockdown, was really great in terms of opiates and drugs. The drug supply almost dried up. People couldn't beg, and that was fantastic. It is tailing off a little bit. We are excited to be hopefully involved with the PHE initiative from Rough Sleepers about how we can keep that kind of good feeling, particularly as those measures have been kind of eased. Residential treatment, we sent 46 people in the first 3 months of the immediate lockdown. I'd like to do a quick kind of, I won't do a quick kind of test, but how much a taxi is between Oxford and Weston-super-Mare. I can tell you it's £612. We spent an awful lot of money on taxis during that time. Some of those people really kind of needed kind of residential. We probably sent 200%, double the number of people that we would usually kind of send in terms of that. We've had, the police have taken quite a few people for us, particularly prolific offenders. And we've also sent quite a few people who were rough sleeping as well. So that's been fantastic. Successful completions, certainly over the last 6 months, our successful completions seems to have very much kind of stayed in terms of that. We were very fortunate. Our commissioners gave us a bit of pass that we didn't need to get. We've got £500,000 payment by results, of which we didn't need to get for the first, but we still got that. So that's fantastic. And just to say, great service user and stakeholder feedback, which we've had around the kind of county. I'll talk a bit quicker now, and it's just a little bit. We do an awful lot of some co-design, and also there's some results there from the service user survey we did last year. We did a big co-production exercise in January this year as part of our new contract. I'm really pleased. As part of our PHE Rough Sleeping, we went out. We only had a couple of weeks, but started doing that kind of involving and co-designing with rough sleepers who are currently accommodated. So we still have 2 units, the YHA in Oxford and also Canterbury House as well. So we've still got almost 90 people who are accommodated, and thinking about how we may particularly kind of continue supporting them. It always interests me about why people do well. I talk a lot to people who are graduating or moving through our service, and sometimes I think they're going to say, I looked at your outstanding CQC, I looked at your wonderful, nice interventions and stuff, but it's, something there from particularly the service user one. It's people who you kind of say, actually, it's the warmth, it's the kind of friendliness I feel when I come in. I love the fact whenever I call up, someone answers the phone, and even though my worker's not there, they say, can I help you? And I do think, that's how we do kind of person-centered care, and how we try and make that a kind of an experience for people who use our service. Next one, please. I think this one's you, Izzy.
Okay. So yeah, I was a service user for over 25 years. And what I found towards the end of my using is I went into quite a dark place. I was cuckooed, and it wasn't until the intervention from the services that helped break that cycle for me. Turning point were really engaging with me. They were they stopped all the barriers which normally in the place. So it'd take a while to either get some help or get on a script or get into treatment and that. And they were really proactive in getting me some help. And other services all linked in together. You know, when I went to Turning Point, they managed to get me into a residential treatment. And that, from that point on, when I came back out, they were really engaging as well. So there was a lot of aftercare offered to me as well, which in the past I'd been in and out of detoxes and things like that, and I'd always picked up again. So this time I had that interaction with someone as soon as I got out of treatment. I was offered aftercare. I was offered a peer mentor course, which for me at that point was amazing. You know, it gave me the chance to give back, do something constructive with my time, and show people that came to the service that knew me that people can change. It was about returning to education, and building a support network, and understanding how the service worked. You know, I got a different view from what it used to be. You know, I used to turn up at that service and I'd interact with my key worker. And when he wasn't there, other people would interact with me. You know, it had a real family vibe going on in there, and it made me feel really welcome to keep coming back. So yeah, a lot of praise for Turning Point. And as through that peer mentor course, it built my confidence up into being able to start applying for work. You know, and I got a job with the Hep C Trust as a peer support lead for the Thames Valley area. And that covers Oxford, Swindon, Milton Keynes, Reading and Slough, and building relationships with the services in those areas, you know. And I had a great start in Oxford, because what I've noticed at Oxford for that area, it worked really well, you know, with the outreach. They've got outreach at Turning Point, there's outreach with St Mungo's, there's linkage with all the services, you know. And if we need to find something, it's quite easy. There's always somewhere we can get help to find someone anyway. And what we do is we do testing. We test people, and we go to hostels, and we find pathways with the nurses that we've got to get people into treatment. What we do is I help support them through the treatment process, build a peer support lead. So we have a team of peer mentors as well within the peer Hep C Trust that do the same stuff as me, helping bringing people into appointments. You know, Hep C is not one of their priorities. So what we do is try and make the process as easy as possible for them by bringing them to appointments. You know, during the COVID lockdown, the nurses were all taken back to the hospital. So what I had to do was then deliver medication, check in with everyone. What the nurses would normally do was hand it over to me. And with Turning Point's help as well, we found a lot of people that were through treatment, that needed the help and support, and we carried that on. So through the lockdown, we were working pretty much all the way through it. And gradually, as we got nurses back, we were able to start doing the treatment again and start screening people. And with everyone being housed in these hostels and that, we've linked in with St Mungo's in Oxford, and we were able to go into the YHA, the Travel Lodge, a few of the other hotels, and now there's a new one, Canterbury House, and the same in other areas. But what I've noticed is there's a massive difference in how the services work across my area. Some areas don't have an outreach program, which makes it really difficult. Some services don't have night shelters and things like that. You know, there's like a template that we can go into an area and we can find these places, and it works. When there's not that infrastructure in other areas, it's really difficult to start building it up. But Oxford is doing really well with this, you know, and we've linked in with everyone, and it's about trying to carry that on to other services, you know, let them know what we're doing in each area, so they can start, you know. Other areas are still on lockdown, like Reading, Slough. They're not seeing any clients, same as in Milton Keynes. But yeah, hopefully it's going to start opening up again. Thank you.
You're on mute, Andy.
Sorry, there we go. Lucky you lot, me being on mute. Thanks, Izzy. That was fantastic and brilliant. kind of slides then. I suppose just what we would do differently. I think for me, and these are kind of from my perspective in kind of Oxfordshire, I suppose that understanding, nobody has the silver bullet, and if I get asked another time by one of my managers or by one of my staff, what's the plan or what's the policy on this? There is lots of guidance there. There is lots and lots, and we are in difficult times. But I think one of the things which we've encouraged, particularly kind of workers and service delivery, but also in terms of how we do that, it is understanding it's about kind of working through some of those bits. The next bit, unilateral plans have limitations sometimes. As I've said, we do things very differently across our kind of county. So we don't spend lots of time sitting in meetings about a county-wide kind of approach. And then some of the bits there, lots of people don't eat sausages. And I'm always very aware of about how much services can appear a little bit like the sausage machines. There are lots of vegans, there's lots of all sorts of people, but how you make that kind of personalised kind of service delivery is really kind of key, really. Short-term plans, we clearly need to be flexible and agile. Touch wood, I've not had a single worker yet who's had a known case of COVID-19. I'm not sure whether that's good luck or good planning, but clearly we work on the basis that, it's a matter of when rather than if. And, this, and we'd have to close one of our hubs maybe for 2 or 3 days. Clearly, the rate of infections is going up. But we are still doing a lot of the work, which particularly on that kind of outreach kind of basis. Collaboration, there's been great. One of the things, there are just lots of wonderful organisations. COVID, people have the same kind of approach as us, who want to go out, who want to make a difference to people. I remember talking to the clinical lead of the ODN, particularly when the nurses are being released back into kind of services, saying, we've got a good opportunity here. Let's try and be doing a bit more Hep C testing and treatment in some of the hotels. And a week later, we started doing some testings in one of the hotels, which is fantastic. Next slide, last couple. Sorry, hopefully, am I not running too much over, am I? So I was asked what makes us proud. So it's just a collection of kind of pictures here. The one in the top left is some people working one of the hotels with their PPE on and stuff like that. The top right is a couple of peer mentors who are still wanted to come in. It's great, we completely re-landscaped the whole of our garden in a lot of in our Oxford hub. They were in there on a reduction day, coming in, kind of helping out. The person in the middle is a rough sleeper called Johnny. He's probably one of the people that has come the closest to be banned in our service in the last 5 years. He was even on my caseload for a while. And he is someone who right at the start of the lockdown, was probably drinking a bottle, was begging enough to buy a bottle of vodka or sometimes 2 bottles of vodka a day. He literally had the clothes on his back and was going to be moved in one of the travel lodges. And we did a bit of work with Johnny and said, would you like to go to rehab? We made that happen. We went to Sports Direct and bought him a load of stuff to wear to rehab. He literally had nothing. Other sports brands are available. And we took him there. And, Johnny did really well. For the first, did his detox. I think after the first month, he then lapsed, came out. We got a phone call from, of all places, ED in Bradford, saying that he was in the waiting room. What would we do? We had to arrange a taxi for Johnny to get him back and to restart his detox. And unfortunately, last week he was back on the streets in Oxford. But so am I proud? I think sometimes we work in this, it's worked or hasn't worked, but someone who's been drinking over a bottle of vodka probably for more than a decade, is probably in the last 6 months only been drinking probably a couple of weeks and done really well, and sent someone out today to try and find Johnny, and let's do what we can to try and get him back in there, really. On the left, we still have lots of successful completions, with lots of people coming through the service. The one on the bottom, was our wonderful clinical psychologist came in on a Saturday morning and sent out 123 naloxone kits to service users that we couldn't find out that had them within the last kind of quarter. You know, I have a data person who goes through the entire prescribing cohort every Sunday and sends me the data first thing on a Monday morning, so we can go into some detail about exactly who is on, who is off. And I have workers who consistently, all the way through the pandemic, who have done 120 interventions every single week on the system. And the last picture just on the right there is a picture of Elvis. I think the Deputy Director of Social Care sent me this and just said, thank you very much, you're awesome. And it's great to have great working relationships. I could equally send that to lots of other places as well. And it's just been great about how organisations have come together, really. Last slide. Last bit. So just a couple of final bits, new ways of working. You know, I seem to spend my life in thinking about new ways of working, and clearly COVID-19 will be with us for some time to come. I don't see a return to lots of the group work we've been doing. I think personally, and lots of my staff and lots of our service, we miss them. And, you know, certainly thinking about how we do services, how we promote that recovery is really kind of key. And clearly there will be some changes happening. But one of the things which has been really kind of key for us is we've probably seen everyone who's been on a script with us in the last 6 weeks. We've brought people back in expecting that there will be local spikes moving into the autumn and into the winter as well. The PHE, just to talk about the rough, you know, really excited about this. People like I talked about, Johnny, we had another person who went the same day, a bloke called Chad, who only lasted 2 weeks, managed to get arrested, coughed at a policeman and got sent down for 12 months. He's coming out in next month. He may go straight to, but you know, some of the people, and I don't see people like Johnny as a failure. I see them as little steps to big changes. But it does people with complex needs, people who have a history or entrenched rough sleeping, do need that high intensity, probably every day. Organisations working together, very much integrated in the response to make those kind of changes, and therefore working through that is very much welcome. Last couple of bits, just to continue bespoke delivery and stuff. You know, making, you know, our big thing to all treatment providers is how do we make treatment more attractive? How do we make it more enjoyable, as Izzy was talking about? And how do we aspire to give better outcomes for people who are obviously kind of have that level of need, and how we're going forward? But just to say, it's going to be tough for a while. But, you know, generally overall, we are stronger together. And, you know, certainly in Oxfordshire, I think we've had a fantastic response to COVID-19. And, you know, we look forward to a time when things return back to a little bit more normality. Thank you very much.
That's wonderful. Thanks ever so much, Andy. And I realise we've kind of taken a huge amount of time to go through that, but I thought it was really important to listen to all of it, because it was hugely valuable and inspirational. And thanks, Izzy, ever so much for sharing your story, because it was wonderful to hear. And you'll see from the comments that everybody was really appreciative of you sharing that story and the phenomenal work you've been doing as a result of that. We have only got 10 minutes left, but I'm keen for Juliet to do her bit, if that's okay, Juliet. We've got a few little bits to update on from a national NHSE perspective. There's not a huge amount from a PHE update perspective, and there are a couple of questions in the bar for Andy and co. So we'll collate those and get some responses from colleagues and share those with you after the meeting. But Juliet, would you mind just whizzing through yours? Is that okay?
I will whiz through, yes.
Sorry about that.
It's going to be a very quick whiz through, isn't it? That's fine. And actually, Andy, is, you know, as you say, it was a brilliant presentation. I'm sorry I'm not going to put my camera on because my laptop is playing up and I think I might lose everybody if not. So I'll put it on right at the end just to say hello. But and in a way, my presentation sort of, you know, much more high level than Andy's, and his sort of gives you what really happens at the other end of what we try and do in the commissioning side. So I was asked to sort of look at what sort of services we commission in Oxfordshire and the sort of outcome based type contracts that we've tried to put together, and the types of things that we're doing ongoing. So if we go on to the next slide. Just to say, I'm the Mental Health Commissioner and LD Commissioner in Oxfordshire CCG, and part of a joint commissioning team, which then homelessness is within our portfolio. So we work very closely with our colleagues, and I'm looking at this through the sort of NHS lens. So if there's any other Oxfordshire colleagues on the call, they might want to call me out about some of the things I say. So happy to do that. So this is like broadly really just gives us what we're actually trying to do from an NHS commissioning perspective in terms of what we're understanding the health needs of the population that we serve, and then commissioning those services that meet those needs. And we're trying to make sure that we're improving the health and care outcomes of people, making sure that we're addressing inequalities, and obviously homelessness is very high on that list, joining up services that work together, and really thinking about how we focus on early intervention and prevention, so working very closely with our public health colleagues in the local authority as well. Just a quick mention about the CCG, because although I was asked to talk about the CCG, that they're probably on their way out, to be honest. So the sort of future is looking at much more integrated ways of working, which obviously is only a good thing. That'll be on sort of different footprints, if you like. So there's an integrated care system, which is a bigger footprint, looking really at sort of monitoring and self-assuring ourselves against some of the NHS standards, and thinking about how we're actually using resources. And for us, that's Berkshire, Buckinghamshire and Oxfordshire. And then there's an integrated care partnership, which is much more based, which for us is Oxfordshire, and that's about trying to bring together providers and commissioners much more closely together to work together to think about how to deliver services together and think about the person as a whole. And again, from a primary care network perspective, that is coming down to the next level of networks of 50,000 patients around sort of 3 practices working together to provide services around their population, and really build on the increased connections with communities that they serve. So next slide. So in Oxfordshire, we've been very fortunate. We've got a mature pooled budget arrangement, which means that we're putting money together between different sort of statutory organisations, and we've got ones that relate to homelessness is a housing related support, which includes the district, city council, county council and ourselves, and also one that has got a lot of health money, and social care actually money in it, because it's for mental health and learning disabilities, but also for some other care groups like ABI, etc. So we're lucky in Oxfordshire that we actually do all talk to each other from a county council and local authority, provider and NHS perspective. We were one of the first people to put an outcomes-based contract together for mental health services. So that's been going for about 5 years now, and it's focusing on severe mental illness. And we've got a proportion of it, a bit like Andy was saying, proportion of his contracts around incentives. So is this contract. So the outcomes part of the contract is focusing on people's recovery, well-being, delivery of the long-term plan. What we've got is a partnership within that contract. So there's provider and yes, I could share my I will share it. In the chat it says I'll share it. And we've got there's the Oxford Health Foundation Trust to the main lead provider, and then there's 5 third sector partners who are part of that contract, and some of them that Andy was mentioning in terms of response and restore, etc., that are providers out there doing all sorts of different work in different settings. Social care and supported living pathways also within that contract. So we're trying to move people through from intensive support through to independent living out into the community. And the homeless pathway, we've still got work to do. I'm not saying of this is all singing or dancing yet, but you know that we've got very good connections. We're all talking to each other. There's sometimes challenging situations of trying to get people you know, out of hospital onto the homeless pathway, but the main thing is that we all sort of talk to each other and try and work through those challenges. The other thing that people sort of know us for quite well is Luther Street, which is our primary medical services practice in Oxford, which I think Andy obviously mentioned in his presentation as well. They've retained their contract that started a sort of recommissioned contract in April, and they are sort of the experts around homelessness in Oxford and provide all of the health services that you would expect from a GP surgery, but are very, very collaborative in their approach and making sure that they're linking in with voluntary sector agencies so that you've got that holistic care. And what we're trying to do is also make sure that actually they've got reach across Oxfordshire. So we're trying to get ways of making their sort of practice, if you like, the clinical lead for Oxfordshire as well as it is for Oxford. It's actually for the county, because there's, you know, obviously in other districts they're also needing advice, help, and sort of thinking about how we sort of reach out to some of the other GP practices to maybe become role models like themselves. So next slide. Sorry, I know the time is just about to go. I probably don't need to concentrate on this slide really. If you want to do more about outcomes in another time, I'm more than happy to do that again.
Fantastic.
And the next slide is really about what more things that we can do and opportunities that we've got around the long-term plan. We've done a health needs assessment in Oxfordshire. We're thinking about how we can improve those primary care services across the county. We're also recommissioning the services for homeless adults that we've got in the pool budget, and thinking about how we obviously learn from COVID around all of that as well, and then how the PCNs and the ICP can sort of enable us to talk to each other more moving forward and make sure that the system becomes as coherent as possible, because I think we've got great leadership and sort of aligned views within the county. What we need to do is to make sure it's pushed down to frontline services so that everybody understand, you know, thinks about where the pathways work and how we all work with each other in a sort of more streamlined way. And
That's fantastic.
that was a bit of a whiz through, but anyway.
That was really brilliant, and I think we will definitely take you up on the offer of coming back to talk to us a bit more about outcomes, and actually might be useful to have a little bit of the session connected to that around your needs assessment, and some of the priorities that you've picked up as a result of that may have led to the development of your outcomes as well, because I think that might be useful for colleagues to hear a bit more about too, if that would be possible.
If you want to put some more specific questions together, then please do, because it was a bit, you know, widespread that, so you might want, you know, some more so that's fine.
We'll catch up with you and have a little bit of more of a think through that, if that's okay.
That's great.
Thank you ever so much, and again thanks to colleagues Andy, Izzy and Juliet for doing that for us today, and for sharing your